Hello, I'm Dr. Jeanne Ashworth. I'm a radiation oncologist at OhioHealth. Welcome to the OhioHealth Cancer Survivorship video lecture series. So, if you're watching this, most likely you or someone close to you has recently been diagnosed with cancer, or at least a suspicion of cancer. This can be a time of anxiety and confusion. I'm hoping to be able to shed some light on this process and help you understand what to expect following your cancer diagnosis. So, one of the things that cancer patients can expect are tests. Tests are done first to establish the diagnosis of cancer, or in some cases to rule it out. They're also done to establish the type of cancer, which is typically related to the cells the cancer came from. They're also done to evaluate the specific features of a cancer. For instance, is it an aggressive cancer or a slow-growing cancer, one that's more or less likely to spread? Is it likely to be sensitive to hormonal therapy if it's breast cancer? Is it likely to be responsive to newer immunotherapies or targeted therapies? These tests are also done to establish the extent of the cancer, which is also known as stage. For some patients, testing may be done to evaluate a genetic or inheritable mutation. And most importantly, your tests are being done to guide your cancer treatment. So, in order to establish a diagnosis of cancer, a biopsy is very commonly done. This may follow a suspicious test, such as an elevated PSA, an abnormal mammogram, or an abnormal finding on a lung cancer screening CAT scan. In other cases, a biopsy may be based on symptoms, such as pain, bleeding, or weight loss, or findings of a mass on physical examination. A biopsy is sometimes performed as part of a screening procedure, such as a colonoscopy. But in almost every case, a tissue sampling is required in order to establish a diagnosis of cancer. So how are biopsies done? Typically, they involve the removal of a small sample of cancer cells or tissue using a small needle or a pincher. These are often performed by radiologists using image guidance, such as ultrasound, mammogram, or CAT scan. They may also be performed by surgeons or other specialists. For instance, stomach and colon cancers are often performed as part of endoscopy evaluations, in which case those tiny little pinchers are attached to the scopes themselves. Prostate biopsies are performed by urologists in conjunction with the prostate ultrasound. For patients suspected of having lung cancer, these procedures are done by lung specialists or pulmonologists who, again, will run a tiny little scope into the patient's breathing passages or bronchial tubes to look for abnormal lesions, to gather cells, and potentially to take samples of any suspicious-looking lymph nodes. Skin biopsies are commonly done by dermatologists. One of the concerns that patients may have when they hear biopsy or tissue sampling is, will it hurt? So fortunately, these are usually done under a local anesthetic or numbing medicine, which is typically applied to the area to be sampled. So if the area to be sampled is the breast or the prostate or a skin lesion or a lymph node, that local anesthetic will be directly applied prior to the biopsy being taken. If the biopsy is being done using a needle to reach a deeper tissue, such as the lung, numbing medicine will be applied to the skin and the underlying tissues prior to the needle being introduced. So one of the important things we need to know for a patient who's been diagnosed with cancer is exactly where that cancer is. First, that means where did it start, also referred to as the primary site of malignancy. This is often, but not always, the area that's been biopsied. Next, we have to address whether it's spread through the lymphatic system to lymph nodes, which are small filters along the lymphatic system that can trap cancer cells. Spread through the lymphatic system into lymph nodes is called regional spread. We also want to know if the cancer has potentially spread elsewhere in the body through the bloodstream, a process known as distant spread or metastasis. Establishing the extent and size of cancer establishes the stage of disease and the appropriate treatment for that cancer. This is often done through a combination of physical examination and imaging studies. However, microscopic disease is not always apparent on either exam or imaging studies. So the most accurate way to stage a cancer may occur at the time of surgery, after removal of the cancer and surrounding lymph nodes. This is known as pathological staging. In the process of looking for cancer, you can expect some radiographic studies. These may initially be screening tests for patients who do not have known cancers, but are at risk for them based on their age and gender. They can include mammogram, CT chest to look for lung cancer. If a suspicious area is found based on screening studies, additional testing known as diagnostic studies may be performed. So, for instance, if a patient has an abnormal appearing area on a mammogram, they may have additional studies such as ultrasound or in some cases breast MRI to provide better information about the size and features of the lesion seen and whether it needs to be biopsied, as well as what the best way of going about that biopsy may be. A PET-CT image may be used following an abnormal finding on a CAT scan, either a screening scan or perhaps a scan done for a completely different reason, such as looking for kidney stones. MRI is occasionally used for diagnosis, for instance, for patients with breast cancer, or for patients who have neurological symptoms concerning for brain cancer or brain involvement. Along with diagnostic studies, a patient may undergo additional screening studies, and these are done to establish whether the cancer is confined or has potentially spread to other areas. These may again include CT scan, PET-CT, bone scan, or MRI. Which staging studies are done and whether a patient even needs to have staging studies is determined by the specific type of cancer and its risk for spread. So for some early cancers like breast cancer or favorable prostate cancers, staging studies may not be required. So what are these tests anyway? An ultrasound is a machine that uses sound waves to visualize either a mass, such as something found in the breast, or a structure, such as the prostate, and to help guide biopsy. A CT scan is a three-dimensional X-ray which can show a mass or enlarged lymph nodes in relationship to the normal anatomy around it. A CT scan is basically an open cylinder like a donut. It's usually a pretty quick test. It may involve contrast into the vein for better imaging. An MRI scan is similar to a CT but uses magnetic imaging. It is typically a bit longer test that can take up to an hour, and as patients who've been through them know, it can also be somewhat loud. Typically these are done in closed tubes to get the best images, but for patients who are claustrophobic, open MRI imaging may be utilized instead. A PET-CT is a combination of a CAT scan and a nuclear medicine test in which a radioactive version of sugar is ingested into the bloodstream to look for cells that are rapidly dividing. These cells will then show up as bright spots on the PET-CT scanner. These tests are also a little bit more time-consuming and involve the initial injection and a period of wait, followed by a whole-body scan. Along with testing, you can expect to see a lot of doctors as part of your cancer journey. Your team of doctors will work together in establishing a diagnosis and recommending treatment. This team will include, in many cases, radiologists, pathologists, surgeons, radiation oncologists, and medical oncologists. The teams of doctors involved in cancer care meet regularly to review patients' information and to make treatment recommendations at meetings referred to as tumor boards or cancer conferences. Sometimes there's some uncertainty or disagreement as to how best to proceed following a cancer diagnosis. In these instances, we are able here at OhioHealth to rely on our colleagues at MD Anderson as part of the MD Anderson Cancer Network. So for these patients, what we'll do is download information on the patients, including their test results, and request a consultation from one or more MD Anderson physicians who specialize in that type of cancer. Typically, we hear back from those physicians in 1 to 2 days. They'll call us, discuss the patient, and make their recommendations. So cancer teams often include surgeons. Surgeons' role is to sample and remove cancers, including both the primary cancer and potentially lymph nodes surrounding it. These can include general surgeons who treat patients with colorectal, thyroid, and breast cancers, urologists who treat prostate and bladder cancers, gynecological oncologists who treat uterine, cervical, ovarian cancers, thoracic surgeons who treat lung and esophageal cancers, head and neck surgeons, dermatologists, surgical oncologists, neurosurgeons, and orthopedic oncologists. Radiation oncologists may also be part of a cancer team. We use directed high-energy X-rays to kill cancer cells. We also monitor and treat the side effects that may be associated with that treatment. There are different types of radiation that can be given. Definitive radiation is often given as an alternative to surgery, for instance, for patients with prostate cancer or early lung cancer. Definitive radiation may also be given for patients who have more advanced or inoperable cancers, and in these instances, it's often given along with chemotherapy. Neoadjuvant radiation refers to treatment that's given prior to surgery in order to shrink a cancer down and allow for its complete removal at the time of surgery. This is common in rectal, pancreatic, and esophageal cancers. Likewise, we sometimes deliver radiation following surgery in order to kill off any microscopic disease that could potentially be left behind, a process known as adjuvant treatment. Finally, there's palliative radiation, which is typically a very short course of treatment used specifically with the goal of relieving symptoms such as cancer-related pain. Radiation oncology involves a lot of technology, so if you are in the radiation oncology department, you'll probably come in contact with that. The first thing after consultation that you might see is a CT simulation. This uses special modes and CT scanner in order to establish a stable treatment position and image the area to be treated. After that, we proceed with treatment planning, which uses sophisticated computers and a team including the radiation oncologist, a dosimetrist who does dose calculations, a medical physicist, in order to direct, plan, and calculate radiation treatments. The machines that deliver the daily treatment are called linear accelerators. The daily treatments typically take about 10 to 15 minutes. They're painless, and directed radiation is given under the guidance of radiation therapists. Image guidance is often a part of modern-day radiation, and this entails the use of imaging studies such as X-rays or CAT scans prior to daily treatment to improve targeting. Finally, there's a lot of quality assurance involved with radiation therapy. This is done by our medical physicists who are constantly monitoring the machines to ensure that the correct dose and targeting is being delivered. It's done by peer review group in which radiation oncologists review their cases with colleagues prior to initiation of treatment. And it's done by accrediting agencies such as the American College of Radiology, which ensures that treatments are being given in a method that's consistent with national standards. In the modern era, misadministrations of radiation or mistreatments are extremely rare. It's not uncommon that a busy treatment facility, which delivers thousands of treatments per year, can go many years without a single misadministration. Medical oncologists are also often involved in cancer care. For patients with more advanced or complex malignancies, I like to think of them as the captain of the ship. They recommend and administer systemic treatments to treat cancer. Again, like radiation, this can be given prior to surgery in a neoadjuvant setting. It can be definitive treatment for patients who have very sensitive cancers to chemotherapy, such as lymphomas. Definitive treatment can also be given along with radiation for inoperable tumors. Chemotherapy can be given after surgery to reduce the risk of spread elsewhere in the body, a process called adjuvant treatment. And palliative chemotherapy can be given for patients who have incurable cancers in order to improve the quality of life and extend life in certain settings. Medical oncologists, along with delivering these treatments, also will monitor and treat side effects associated with treatment. For chemotherapy, these could include nausea, vomiting, diarrhea, decreased immunity, and fatigue. And finally, they're often involved in the long-term follow-up of cancer patients after treatment. So there are various types of systemic therapies that are administered by medical oncologists, including chemotherapy, which kills cells that are rapidly dividing. Because normal cells within the body may also be dividing, we can see some side effects associated with chemotherapy. Newer targeted therapies target specific mutations within cancers and primarily impact cancer cells. These can include treatments like Herceptin or Perjeta for breast cancer and some newer oral chemotherapies. Hormonal therapies are used to reduce or block hormones in the setting of cancers that are hormone sensitive or being encouraged to grow by the presence of hormones. This is generally true for breast and prostate cancers. Immunotherapy is kind of the new kid on the block. It's a treatment which engages the body's immune system to fight cancer. Finally, special cancer mutation testing may be required to determine the best type of cancer treatment. This may, in some cases, require a second biopsy, but typically entails sending of a cancer sample to a lab which does a detailed analysis, which may take 2 or 3 weeks. Along with the doctors, we can't forget the nurses as part of the cancer team. A lot of my patients tell me that the nurses are their best friends through their journey with cancer. Nurses help in evaluating and managing symptoms associated with both the cancer and the treatment. They can identify barriers to care, including transportation issues, insurance concerns, and anxiety. They may help schedule tests or office appointments, and they can communicate with patients, doctors, and other team members. A special type of nurse called a clinical research nurse may, in some cases, be there to enroll patients in clinical cancer trials. Additional supportive services are available for cancer patients through OhioHealth, which include nutritional services, oncology rehab, such as physical therapy, occupational therapy, or speech therapy, lymphedema therapy, psychosocial services, integrative medicine, cold capping, which is used to reduce potential for hair loss during chemotherapy, and cancer wellness fitness programs. Some patients following a diagnosis with cancer may be referred to a cancer geneticist. This is an individual who sees patients with higher risk of genetic or inheritable cancers based on the type of cancer, the age of diagnosis, and family history. The cancer geneticist may order a blood test to determine whether that individual has an inheritable genetic mutation. The results may be expedited for some patients for whom it would impact treatment decisions. For instance, for a breast cancer patient trying to decide on whether or not to undergo a bilateral mastectomy. A finding of a genetic mutation may result in recommendations for additional screenings and follow-up based on results. And while most cancers are not associated with identifiable genetic mutations, it's important to have this information, both for the cancer patient themselves and for their family members. Finally, I want to mention the cancer navigators, the patient navigators who are involved in this process. I'm going to repeat that. Finally, I want to mention the patient navigators who are an important part of this process. They help to schedule and expedite tests and doctor's appointments. They can help coordinate care between different care providers, and they ensure that no one, quote, falls through the cracks. They address barriers to care and may answer questions or find answers to questions that patients have. Navigators are often involved very early in the cancer process, sometimes even prior to diagnosis, and will follow patients typically through the initiation of treatment. Finally, I know that cancer can be overwhelming. I want to encourage cancer patients to ask questions of their doctors, of their nurses, of their navigators, and to seek information. There's information available through my chart, which can include test results and clinic notes. Information is also available through other people who've gone through this process. Don't be afraid to ask for help. Your cancer team is there to help guide you along the way. And while your doctors are there to make recommendations for treatment, remember that you are the ultimate decision maker in your cancer care. Thank you.